We would like to start our session, and we would like to introduce Professor Samir Naim, Professor of Internal Medicine at Alexandria University, and he is going to be speaking about type 2 diabetes, complications, burden, and time for prevention. Welcome, Dr. Samir.
Thank you, Mr. Chairman. Thank you very much for your kind introduction, and allow me first to thank Professor Ines for her kind invitation, as well as Sanofi for inviting me to share in the first CRM meeting of the ASD. And I will be speaking about the burden of type 2 diabetes complication. And these are my disclosures. And I will start by the magnitude of the problem. And I think most of us, we are aware about this problem that in our area, in Orange, the Middle East, North Africa, that the problem is growing. So by 2045, we'll be having doubling of patients with type 2 diabetes. And the most important thing that for everyone with type 2 diabetes, one is not diagnosed. At the same time, the number of patients with impaired fasting glycemia, as you see in the MENA region, is getting closer to those with diabetes. And the most recent update from the IDF that now in Egypt we've got about more than 10 million, so about 1/7 of the MENA region, and this is expected to grow, as I told you, to double in 15 years. And diabetes is not strange for us, you know, in the famous papyrus paper discovered by the German scientist Ebers. This was 1500 years before Christ, and they discovered, or they described, a person with excessive urination, and mostly it was diabetes. But in the recent era, and you remember those who are as old as myself, that back in the 1971 there was a stamp describing this papyrus paper, and you can see the price of the stamp was 20 millim, which is, millim is a unit for the Egyptian pound at that time. And from the Ministry of Health, back in almost 20 years ago, they have done a research, and you see that there are a lot of complications in diabetes in Egypt: retinopathy, neuropathy, nephropathy, cardiovascular, and foot ulcers, and amputation. And in the famous Egyptian renal registry, back in 1996, they described that 9% of patients with chronic renal failure are due to diabetes, and just jumped to 15% in 2001. This means 20 years. So now we don't have a registry, but expect it to be more and more. And recently in Alexandria, a piece of research was done by our dear colleague and friend, Professor Samir Helmi Asad Khalil, and in his group, they discussed, or they done a research on the prevalence of chronic diabetes complication. And let me share some of the problems in Egypt. About those who are having diabetes, about 30%, they do have peripheral neuropathy. But look at that, 3% were in newly diagnosed diabetes, not settled. And also in diabetic kidney disease, about 1/2 of patients, they have diabetic kidney disease, and 10% of newly diagnosed. And also in retinopathy, half they do have retinopathy, 10% in those newly diagnosed diabetes, they've got retinopathy. And the same applies for peripheral arterial disease. So this gives the notion that this complication can occur early enough. You don't have to wait to have diabetes for 10 or 20 years to have this sort of complications. And in the same research, they showed that the complications they can share together. So you can have diabetic kidney disease, neuropathy and retinopathy, and peripheral artery disease in patients with type 2 diabetes. And this will be translated into expense, because the more complication we're having in Egypt and all over the world due to diabetes, we get more expense. You can see this graph from the IDF again, that the expenses, whether in US dollar or other identicals in other countries, is growing up. If you compare it as well to the gross domestic product, you see in our area, the MENA, 1% of the gross domestic product is paid for the diabetes-related complication. And this is not a very small sum. It's comparable to 1.7 in North America. So we are paying a lot to treat the diabetes-related complication in our beloved country. And we have to remind ourselves about this. Small vessel complication, large vessel. Small vessel diabetic retinopathy, leading cause of blindness in adults. Diabetic nephropathy, leading cause of end-stage renal disease. Double or triple or fourth time stroke. 80% of cardiovascular patients with diabetes, they do have cardiovascular disease in addition to diabetic neuropathy. And let me go back to 1970s when I was a resident at the Alexandria Medical School. And at that time, we were taught that you have to treat your patient diabetes to decrease the symptoms, the form of weight loss, polyuria, and polydipsia, to avoid acute complications like DKA and hyperosmolar coma, to avoid bad post-operative wound healing, and to avoid infection. This was in 1970s. But in 2022 and 23, we have to change our attitude. Definitely the story is completely different. You can see that on the left side that we've got the package is not only diabetes, is not only glycemia. The package will include blood pressure, lipids, smoking, and others. And on the right side, you can see the package is not only heart, but also kidney, also dementia, metabolic problems, neuropathy, retinopathy. See, it's a whole package. And this is the aim of the CRM, the topic for today's discussion. So it seems that in 2022 and 23, we have to change our attitude. The role of glycemia is very important. It had been shown in the UKPDS study, this was dating since present in the last century, that they showed that for every 1% increase in hemoglobin A1C above 6, you get more 21% increase in the diabetes-related points as well as other, and 37% increase in the risk of microvascular complication. And it has been known that if you achieve the target for type 2 in Egypt, or following the target of 7, this will reduce in patients with type 2 diabetes by the famous UKPDS study. Remember, this was the first study to show that if you reduce the blood sugar, you get less complication. And when you were in Stockholm a month ago, Rory Holman presented the UKPDS 44. This is 44 years after the start of UKPDS. And remember, the UKPDS was started in 1977, the year I was graduated from the medical school. And it included about 5,000 patients with naive for any treatment, the first time to be diagnosed diabetes, and they're divided into 3 arms, those taking sulfonylurea and insulin to control the blood sugar, conventional diet, this is the second arm, and the third arm receiving metformin for intensive glycemic control. And in 1997, we have known that if you control the blood sugar, you will get better results. But 10 years later, in 2007, they showed that this effect is persistent. And now in 2021, 44 years after the start of the study, they did show that if you have a good start with a good glycemic control 44 years earlier, this will have an impact on the complication, whatever is your blood sugar later on. And you can see this is the data presented by Rory Holman, that in 44 years there was persistent improvement in any diabetes-related endpoint with glucose control by insulin or sulfonylureas, And the same apply for microvascular disease, and the same apply for the intensive arm, metformin, although it was about 300, it's a very small number, but yet the data are very clear that there was persistent, if you control your blood sugar early enough. And what they did, Roy Horman and his colleagues, and that they had two scenarios. The first scenario is number one, if a patient persisted with hemoglobin A1C at 8 for 10 years, and then later on they decided to reduce it to 7, you get 6% relative risk reduction for death. On the other hand, another patient starting to have a good control down to 7, early enough, you can get almost 3 times improvement in the rate of death. This means that the good start is very important. So not only control of blood sugar, but early control. Of course, this is ideal, but you can see that the control of diabetes for the patient with diabetes and for the physician, it requires a good physical activity, good nutrition, good blood glucose monitoring, following the drugs, avoiding hypoglycemia, and adherence. And this is the main problem, that we are not following, neither the patient nor us, following the rules. And you can see that the problem is not only in the patient, maybe patient one side, the problem may be in us, in the healthcare providers, and in the system and practice. Another pillar is important is the control of lipids. You can see that here, if you very bad lipid control will affect the kidney, and of course the kidney will affect the heart. Very bad lipid will affect the heart as well. So this is interrelationships. That's why there is cardio-renal metabolic again. And that's why in the ADA 2022, apart from glycemic control, lipid controls, they consider blood pressure control and the use of new agent with cardio-renal protection. And you can see this is where we have heard that several times, but you have to stress to your patient that glucose control is important, blood pressure control, and these are the targets, LDL control according to the risk, lifestyle, kidney function, and the use of the new medication to provide renal protection is very important. And despite of that, you can see, this is the international data, and we've got our own data in Egypt, the IDSM. You have seen that more than 17% of patients did not reach a glycemic. And only 1 to 12% actually they are achieving the multiple goal of sugar, lipids, and blood pressure. So it seems that the story is not very encouraging up till now. That's why the recent guidelines presented again in Stockholm last September, when Melanie Davis stood with John Buse and Chantal Mathieu, they presented the new, not guidelines, or maybe the agreement, that they concentrated not only on the glucose, they concentrated on the weight control, on the cardiovascular risk management, and most important, they concentrated on the cardio-renal protection. And cardio-renal protection is important. As you remember the title of presentation, the burden, how can we prevent the burden? How can prevent the complication, not treat the complication? Prevention of complication is very, very important. As I told you, in the study done in Alexandria, the complication actually started very, very early. And you can see that this is a vicious circle. Glycemic control, cardio-renal protection, weight management, and cardiovascular, all this is vicious. You have to start by cutting this vicious circle. And they stressed in the ESD agreement that the care should be very individualized. So it should be patient with, they have their own risk and preference. You have to very, very well follow your patients and avoid iniquity in the delivery. So whatever the level of the patient, you have to follow that and assess the social determinants. So they stressed on this, very important, because the socio-economic and the cost of the medication in consideration to the complication is very important, because comorbidities will cost a lot. As you can see, the cost is going up because of the complications are going up. So the cost is going up. So if you cut down in the complication, you are going to cut down the cost as well. And weight reduction is very important. You don't have to go to the ideal body weight, but 5% can be useful. 10 to 15% you can use your diabetes, and you can get what we call remission of diabetes. And don't be alarmed by this, the new recent guidelines, but let me revise that they stressed again that patient with cardiorenal problem, you have to treat by specific agent, namely the SGLT2 inhibitors, especially if you got heart failure, also CKD and cardiovascular disease. The role of SGLT2 is very important. And for also they stressed on the glycemic control, they put priorities as regards the degree of the anti-glycemic effect and the degree of weight loss. And you can see still the SGLT2, they have got a high efficacy as regards glycemic management. Also they have efficacy for weight loss. So again, if you concentrate on the SGLT inhibitors, one of the newcomers is they've got the intermediate to high efficacy, the hypoglycemia almost none, weight change, of course there is loss of weight change, benefit on the MACE apparent with the CANA and EMPA, heart failure with all of them, and the diabetic kidney disease protection in all of them. And this is very important when you are seeking to protect the patient, your patient, from cardiorenal side effects. And you can see that the protection was not only in the cardiovascular desk, but also for heart failure. And heart failure is an important topic in patients with diabetes. And you have seen all this data, and you can see that in all the EMPA and CANA and DAPA, you get the composite and kidney endpoint is there. Heart failure protection is there, very protective to the kidney and the heart. But going back to the guidelines, you can say guidelines stratify patients into those with complication, those with high risk for complication, and those with low risk for complication. What about those with low risk? Should you treat them? Yes, because as I told you, prevention is very important. Because you have to stress on this, what we call the primary prevention for the complication. Of course, treating this patient is important to control blood sugar, to control the microvascular complication. And again, early glycemic control will help this patient to have less latent side effects. And in the famous DECLARE study on dapagliflozin, they included 60% of these patients, they did not have cardiovascular disease or renal disease. And look at this meta-analysis. And what they showed that in patient, if you see the patient with cardiovascular disease, this line, and those with no cardiovascular disease, the cardiorenal protection was the same. So even if you use these agents early enough, even before renal problem, you can protect this patient. And this is the data again from the DECLARE study. You can see 1/2 of the patient, they did not have any decrease in the estimated GFR, and 2/3 of the patient, they did not have microalbuminuria or increased urinary albumin creatinine ratio. And despite of that, there was a definite renal protection despite the absence of albuminuria or diminution of estimated glomerular filtration rate, and shows that about 60% of the patient in the DECLARE, they did not show any markers of diabetic kidney disease. This means that prevention is very important. So again, this shows that early use of the new drugs like SGLT inhibitors will protect the heart failure, progression of kidney disease, and MACE, cardiovascular death, and all-cause mortality. This is in addition to the control of body weight and control of blood pressure. I will end with a very interesting study. This was done in Korea, and the title was The Risk of Cardiovascular Events and Medical Cost of one of the SGLT2, the DAPA, versus the DPP4 inhibitors. And this was on a big number of patients over 4 years, from 2014 and 2018. They divided into those taking the dapagliflozin, and another arm those taking the DPP4 inhibitor from the registry. And they followed this patient for the adverse cardiovascular outcome. And also they compared the direct medical cost for this. And what I mean by direct is not the cost of the drug, no. It's the cost of the complication. Because if you are paying for the drug and you are paying more for the complication, this is nonsense. So you can see that they got about 250,000, 23,000 were on DAPA and 237 on DPP-4, and this is expected. But because the SGLT2 are much more recently used than the DPP-4. Again, what they found that the MACE was better expected with the dapagliflozin. And again, the estimated medical cost appeared to be lower with dapagliflozin. And this tell you, although the newcomers, the SGLT2 inhibitors and GLP-1, although they are maybe more expensive, but they pay off because you are going to have less complication, so actually the direct cost is very important. And this is the data from the same study, and you can see there was a reduction in the MACE together with the cost, even in those with no previous cardiac problem. And this is another lesson, that early use of this medication will not only control blood sugar, but it will help protection or primary protection against cardiovascular and, as I told earlier, renal. So, Mr. Chairman, ladies and gentlemen, dear professors, at the end, let me remind ourselves that type 2 diabetes is quite heterogeneous. And you have, these patients, they do have high risk of microvascular and macrovascular complication, which is a little burden not only in Egypt, but all over the world. Early glycemic control is important, whatever is the mean, in addition to control of lipids and blood pressure. Person-centered approach is very important. You have to consider the economics, the cost of therapy, the comorbidities, and this is not one-man show and not one specialty. That's why we are here, CRM. And some of the newcomers, some agents actually, in addition to blood sugar control, they can protect the kidneys, they protect the heart, independent of their glucose control. And in the end, let me thank you again. Let me thank the first annual CRM. This is the old port of Alexandria, and this was a sunrise, not sunset, sunrise. And this is the famous library where the sun, Alexandria Library. This is the sun rising, and here is the library. So it was not by mistake, by chance. No, they built the library at the site where sun is rising. And I will be honored to announce that we've got the Egyptian Society of Endocrinology and Obesity 23rd annual meeting is back after being off 3 years because of the COVID. And this is here, inshallah. It will be in the Biblioteca Alexandrina, May 24th and 25th. So you are all invited, and please book your calendar for that event. Thank you very much.
Thank you, Professor Samir Naim, my dear friend, about your elegant talk. I would like to stress on not only on diet control of diabetes or intensive control, but also to avoid complication, we must look for individualization of the patient and put drugs in each place. Also, there is item very important, which is we must treat obesity. Obesity is very important for control of diabetes and for the heart cardiovascular risk, also for the renal risk. So it is very important to look for all this to reduce the burden. And we have just two drugs or two groups affect the burden of the diabetes on the kidney and on the cardiovascular system, SGLT2 and GLP-1. As regard reduction of body weight, as regard decrease in heart failure, even now they are looking not essential, as I said yesterday, that in heart failure, not in acute heart failure with reduced ejection fraction, but even now they use it without acute heart failure in any patient with heart failure, also with renal patient and albuminuria. Thank you, Professor.
Thank you, Professor.
بنشكر دكتور سمير نعيم. فلو ممكن سؤال لحضرتك. حضرتك لما اتكلمت على الستادي بتاعت اليوكي بي دي اس، حضرتك بتتكلم على ان الايرلي كنترول للدايابيتس حتى لو البيشنت ده بعد كده حصل deterioration للكنترول، لا هو بيتر اوت كم عن البيشنت اللي كان بادئ الكنترول بتاعه كويس واتحسن. فهل هي اكتر ريليتد للتايم بتاع الكنترول ده كان امتى، ولا هي اقرب للنمبر اوف ييرز اللي كان البيشنت ده وزين الرينج بتاع HA1C، حاجه كده زي التايمر رينج اللي بنقول عدد الساعات اللي بيكون وزين الرينج، فالعدد السنين اللي هو كان وزين الرينج في ال A1C هي اللي اقرب انها تاثر لي على الاوت كم، ولا الايرلي او الليت؟ وتفسير حضرتك.
طبعا the UKPDS dated for 20 years. You remember 77 and it was presented in 1998. And this is 20 years. They showed there was improvement in the microvascular, not in the macrovascular. 10 years later, they showed that by following the macrovascular showed up. So they got a better control. And also after 44 years. In the graph they have put, this is rather analysis, is not, they didn't have the data that for how long, how many years control it shows. They did 20 years. After 20 years, if the blood sugar goes up, it doesn't matter because in the first 20 years. But I don't know if in the analysis they analyzed year by year. You are right that if you can for 1 year, 2 years, but expected that the more years you are in the good range. This is because of the metabolic memory, the age, the oxidative stress, the epigenetics, all the theories. You know, it will need time. To change the epigenetics, you need time. Thank you.
دكتور سمير لو سمحت سؤال برضه سريع كده. In the treatment or prevention of diabetes or pre-diabetes, would you consider to give medications with legacy effect long run to treat diabetes, or just to control, strict control of blood sugar?
Yeah, it's a very good question, because we have to agree that good control is very important. So we are diabetologists. We are treating blood glucose. Diabetes is blood glucose increase. So we have to treat the blood glucose. Whatever is the mean, whatever, as early enough. If you prevent having from pre-diabetes back to zero, to no pre-diabetes by exercise, it will be good. Not necessarily using the new medication. So the control of everything is okay. If it's not controlled, the use of medication to prevent complication would be better if the patient can afford, because especially with the GLP-1s, they're more expensive. Maybe the GLT-2 are less expensive now than becoming affordable in the last year in our country. دكتور ايمن اتفضل.
الله يخليك، بس هو انا ليا تعليق بس على السؤال الاخير. اعتقد ان هو الفيرست لاين اوف تريتمنت اوف بري دايابيتس هو الدايت والاكسرسايز and education and metformin. بنبتدي metformin as a treatment for pre-diabetes من الأول.
Beforehand, with diabetes prevention trials, beforehand they gave metformin or triglycerin before the rosiglitazone and biglitazone and the lifestyle modification. Now, my question is essentially whether to give medications with legacy effect, changing the type of diabetes, either insulin resistance like biglitazone or something long-run treatment, or just to strict control with any treatment?
Yeah, strict control is very important. With any card you want to play, but go to the end. But if there is compelling indication, heart failure, no. If heart failure or diabetic kidney disease, you have to follow the rule of using the new medication.
Of course,
This is compelling indication.
Individualize your patient.
I think that macrovascular complication of diabetes started before the onset of diabetes. So
Yeah.
in UQPD study, it doesn't show at first there is any improvement or less improvement
Yeah.
with macrovascular
This was in
complication.
1977.
Yes, yes.
Yeah.
So
However,
you-
because this actually, this study, although it got a lot of something missing, but actually changed the way we are thinking about diabetes. Remember, I was a resident. Everybody was teaching that just to control our blood sugar, avoid hypoglycemia. No one was talking about control of long-term complication. Thank you.
Thank you, Professor.